Good afternoon, everyone. Happy Thursday. It's 12:30 here for another edition of Lunch and Learn. We have some special guests today talking about breast cancer screening. And you can see the title slide. Doctors Dang, Speck, and Commander will be talking. Before we get to that presentation, we are very excited to announce that you are now able to claim CME for this talk. It is the same phone number that you've called for CME for partners, and the code is listed here. And that code is JEDTUX for today's talk. There is a limit to when you can claim that code, so please make sure you do that. I will try to show that slide at the end as well. And I also want to tease next week's Lunch and Learn is about melanoma, right in the middle of July. So it's a good one. Dr. Michael Crathen, who's a dermatologist in our community, will be giving a presentation then. With that, I will hand the mic over to whomever would like to talk. Just a reminder that I have muted everyone. If you need to talk, please unmute, and I will continue to do that. If you have any questions for the speakers, please either enter them into the chat box or wait till the end. Thank you.
Thank you so much for that introduction. Dr. Dang and Speck and I are very grateful for the opportunity to share these updates with you today. Next slide, please. So first, we just wanted to state our mission for the Breast Center at Newton-Wellesley. Our mission is to provide high quality, accessible, and equitable care to our patients with benign or malignant breast diseases. And we are excited to partner with you to ensure we are achieving this goal. Next slide, please. Next slide. Great. So we have a wonderful team now working together in our breast center. And this slide really illustrates our outstanding surgical team led by our medical director of surgery, Dr. Michelle Speck, who will be speaking today as well. In addition, we are fortunate to have Dr. Anvi Wen, another exceptional breast surgeon who works closely with us and our patients. We have two wonderful nurse practitioners who primarily work in the breast center seeing high-risk patients, but also help with survivorship care and post-operative care for our patients. And they are Suzanne Giordano and Sylvia Perry. And you may recognize their names because perhaps they've seen some of your patients for high-risk evaluations. We also have a wonderful team of nurse navigators that are excellent at helping our patients get the appropriate appointments when needed. Janet Reeves, Jean Quarantano, and Cheryl Selmash. Next slide, please. In the realm of medical oncology, you see me here. I'm Amy Commander, and I focus on care of women with breast cancer, and I'm also very interested in survivorship care. I'm very fortunate to have an excellent colleague, Dr. Arun Rosenstock, who also sees women with breast cancer and is very interested in counseling those who are considered high risk. So we are happy to help provide oncology care for your patients. And we also are fortunate to have clinical trials available now in our center. Diane Doyle, we need to get her picture here, but she's our nurse practitioner and she provides excellent care for oncology patients as well. Next slide. Finally, these are our amazing colleagues in breast radiology, and Dr. Dang is about to take over. She's our new chief in the Division of Breast Imaging, and she's assembled an outstanding team who provide breast image, read the mammograms, MRIs, and breast ultrasounds for our patients. Some of these names are new to you, and we hope to introduce you to these colleagues over time. Certainly, you know some of the names on this slide. Barbara Ferreira is also on this Zoom meeting, and she's our operations manager, and she really helps the ship run smoothly, so we're very grateful for her. On that note, I'm going to turn this over to Dr. Dang so she can take over.
Thank you for the introduction, Amy, and good afternoon, everyone. So this slide just talks about the breast center as well as breast imaging and hours of operation. I just want you to note that we have expanded post-COVID our hours in breast imaging for screening mammography, and we now offer evening hours Monday through Wednesday as well as Saturday. We've expanded our hours for screening mammography. So next slide, please. Before I go to talking about breast cancer screening, I just wanted to highlight some of the changes and developments in our breast imaging practice. As you may have seen, there are a lot of new faces, and as of January 2020, we are thrilled that we've now transitioned to 100% subspecialty breast imaging practice with fellowship trained or fellowship equivalent breast imagers. And of these, this includes 4 of our new subspecialty breast imagers recruited since November of last year. And we've adopted standardized, improved protocols for our diagnostic workup, our procedures, our reporting. There is more structured reporting and better communication of results. And we've also further expanded our breast MRI program, which is now higher quality, but shorter exams, which are more comfortable for our patients. And we've expanded our breast MRI biopsy program as well. What's great is that our access to biopsies, procedures, and diagnostic workup has significantly improved. And one of the more notable metrics that we have is our screening turnaround time, where majority of the exams should be read within a day of being performed, as you can see here. Next slide, please. So now talking about screening guidelines, I want to start with the gold standard for breast cancer screening, and that is annual mammography. And now 3D mammography in today's era, where annual screening mammography starting at 40 is the recommendation, and there's decades of data that suggests that this saves most lives. If you see this graph here, it highlights the mortality benefit from screening mammography. And as you can see, these are age-adjusted breast cancer mortality rates. And with the widespread use of mammography starting in the late 1980s, there has been a significant decrease, 42% decrease in the mortality from breast cancer in women who are aged 40 to 84 years of age. Next slide, please. And various studies, including randomized control trials, case control studies, and observation studies have again demonstrated almost a 40% drop in breast cancer deaths from screening mammography. In addition to the mortality benefit, screening mammography has other benefits as well. It allows us to detect smaller sub-centimeter cancers that require less extensive treatment, less extensive surgery and chemotherapy. And a recent study even showed that chemotherapy is more effective in women who undergo screening compared to those who don't undergo screening. So again, it just highlights the benefit of annual screening mammography starting at age 40, and that is the gold standard. And irrespective of the risk of a woman, that is a study that should be performed in every woman greater than 40 years of age. Next slide, please. So before I talk about adjunctive or supplemental screening, I just wanted to highlight on a couple of topics, one of them being breast density. As you know, it's gained a lot of just a lot controversy, a lot of it's come into discussion over the last few years with the legislation that we're required to tell women about their breast density. So I just wanted to highlight some points on breast density. What is breast density? It is basically the appearance of the breast tissue on a mammogram, and it depends on breast composition, and we usually assign one of these 4 categories to breast density when we read every mammogram, which is almost entirely fat, scattered fibroglandular density, heterogeneously dense breast, and extremely dense breast. And this density or appearance is dependent on the composition of the breast. So if there is more ductal glandular tissue and stromal elements, the breast would appear dense on a mammogram, and it'll appear whiter on a mammogram, compared to less dense breasts, which have predominantly fatty composition, that would appear fatty or scattered on a mammogram. What I want to highlight though is that next slide. Yeah. Actually, not the slide, just the animation. So what I want to highlight is that 50% of the women lie in the dense category. So it's not something abnormal. That's what I tell my patients, that it's not abnormal. It's just how your breasts are. And half the women have dense breasts. And another thing that's important to note is that there is a great degree of variability or overlap, particularly when we look at the middle 2 categories. It's a subjective assessment by a radiologist, and often we could vary in the two middle categories. So one of my colleagues may call it scattered fibroglandular, but I may steer towards calling it heterogeneous and vice versa. And in fact, data supports that the observer agreement and density assessment, particularly in the middle two categories, is moderate at best. I may myself not agree with myself almost 25% of the times when categorizing breasts. So something to be aware of, that it's not a perfect science. It really is subjective. And density, next slide, please. Density can even change over time with age, with weight change, with hormonal therapy and various other factors. So why is density important? Density is important for two main reasons. One, because traditionally, when we only had 2D mammograms, dense tissue looks white on a mammogram, and cancers or masses also appear white, and they can hide behind this dense tissue. So the masking effect of density decreased the sensitivity of mammography. That has been overcome to a great extent by 3D mammography, as we can see in this example, where there is this speculated mass, a cancer, which is not visible on this dense mammogram, which was 2D. But if you look at the 3D mammogram, it's really beautifully seen here on one of the tomosynthesis slices. So although masking effect is important, it's greatly overcome with our new 3D mammography technology, which is the standard of care for every patient at Newton-Wellesley Hospital. The other factor is that density is an independent risk factor, but it is not as high as previously thought. If you look at the average risk women and density, the relative risk for breast cancer in heterogeneously dense breasts and extremely dense breasts is just to the order of 1.2 and 2 respectively. And just to put perspective, these are the relative risks for other risk factors. So what I want to highlight is, although density is an independent risk factor, it's important, but it's just one of the many risk factors. And we should not forget, or we should not place importance on density so much where other risk factors are a lot more, contributing to the breast cancer risk in women. Next slide, please. So now moving on to the various screening modalities. The left of the screen is mammography and digital breast tomosynthesis. This is the gold standard of the standard screening modality. It's a good test, and our cancer detection rate, which was 4 to 6 per thousand with mammography, is now increased with digital breast tomosynthesis. And if you look at the bottom values are positive predictive values. So the percentage of biopsies that yield a positive result, the positive biopsy rate. And for mammography, it's not a perfect test, but the positive predictive value, which is acceptable nationally, is 25 to 40%. So as I said, mammography is not perfect. In certain women who are higher risk for breast cancer, the sensitivity of mammography is low. And that is when adjunctive screening with MRI plays a role, where the cancer detection, incremental cancer detection rate over mammography is 8 to 10 per thousand cancers. And it's a good test because if you look at the positive predictive value for biopsies, it is comparable or even slightly higher than mammography, 22 to 48%. But what I want to highlight is screening breast ultrasound. Next, please. So if you look at screening breast ultrasound, it is a little bit controversial. Yes, it is a test that shows more cancer in a select group of women, higher density, intermediate risk, and the added cancer yield is 2 to 4 per thousand, but it does come with a cost, and that is why we have to be cautious as to which women we're recommending this test in. If you note, the positive predictive value or the positive biopsy rate for these exams is just 6 to 8%, and see how when it compares to the standard mammography exam. So what that means is that only 6 to 8% of the tests that are biopsied are positive for cancer. And that's what I wanted to highlight, that it's not a perfect test, and it does have a lot of false positive. In fact, escalates this problem of false positive tests that were always, which were sort of a controversial topic, that breast imaging, often over tests and over biopsies. But here, 50% of women have dense breasts. And if we start doing screening ultrasound in all of them, this truly escalates this problem of over testing here. And I'm sure our surgeons can comment on that as well, because they sort of encounter that and counsel patients. Maybe Dr. Speckler.
Yeah, I wanted to add to that. I'm sure Dr. Snyder's patient is going to be a challenge when she comes to the breast center to want her screening ultrasound. But I quite frankly, when I speak to them, I say, listen, if there's 100 of you and we biopsy all of this, the likelihood of finding a cancer is 8%. And so 92% of our biopsies are going to yield benign disease. And, this is a popular tool that's used in New York and Connecticut. And I have patients who come from there and they'll end up with 3 or 4 biopsies. And so I think that the understanding that data really, I think, has helped patients in making the decision to not be too wedded to the screening ultrasounds.
And yes, there is a select group of population where it may be beneficial. And anecdotally, although there are no data, it's these extremely dense breasts where I think you cannot see things on mammogram. And those are the patients who truly may benefit. Younger patients, extremely dense, and they don't quite qualify for screening MRIs. That's where, we should consider those tests. But we want to be aware of the benefits as well as the false positives. Next slide, please. So overall, these are our guidelines where annual screening mammography, which is now tomosynthesis, starting at age 40, is recommended in every woman. But in addition to that, certain group of women, particularly who have a lifetime risk greater than 20% based on various factors such as family history, genetic mutation, radiation to the chest because of lymphoma, amongst others, if their lifetime risk is elevated, they may benefit from screening breast MRI. I do want to highlight that every mammography report that you receive should have an attachment to it, which gives you the, the risk assessment tool that we use and what their percentage lifetime risk is. And then the second category, which we discussed, women who are in the intermediate risk, 15 to 20% with dense breasts, those are the women who should have a discussion about the risks and the true benefits versus, the controversy, the false positives, and, they should be able to make an informed decision about the benefits of this test before they undergo whole breast ultrasound. That is why we encourage you to refer your patients to the Risk Management and Prevention Clinic at Newton-Wellesley Hospital, so that, our providers, our breast surgeons, our advanced practice clinicians, they can go over the data and help patients make, an informed decision about their risk and whether they would benefit from additional imaging. Next slide, please. I just got a chat message that some people lost my sound. Can you all still hear me? Okay. So this is just a chart about how breast imaging has performed during this pandemic. And as you can see, predominantly our work is screening mammography, which was basically shut down during the peak or the surge of the pandemic. As you can see, we were performing close to 180 daily average exams in February. And then as the pandemic hit, by mid-April, we'd gone flat to 0. And then we've slowly started increasing our exams. But what I want to highlight is that as we are approaching our pre-COVID volumes, we cannot do that in the current environment with all the social distancing guidelines. The reason we're able to reach here is because our appointments are longer and we've extended our hours, but we're sort of tight. So our whole breast screening ultrasound, although are now going to be offered, they're still offered in a very reduced capacity because it's an exam which takes 45 minutes and it's a long exam. And as we talked about, the yield is not necessarily that high. So we want to offer it to patients where it is truly indicated rather than all patients. Next slide. So for now, what we have done is that all whole breast screening ultrasound examinations that were supposed to be performed between March and September have been canceled by us, and each of this canceled patient's risk assessment is being recalculated by our excellent breast center colleagues, where they are accounting for breast density, doing a more advanced, improved risk assessment to see if these women truly qualify for ultrasound, or MRI may be the test for them. And then these patients will be contacted by our breast center to set up virtual visits when appropriate, and accordingly exams will be scheduled. I do want to highlight, if you run into trouble and patients really don't want to come to the breast center or discuss their risk, yes, we will be scheduling these exams, but we really encourage, if possible, send them to the risk management clinic and we can, really decide what the best test for them is. They can be scheduled directly via breast imaging as well, and we've provided you the number for that. So I'm going to move on. I'm going to pass over to Dr. Specht, where she can talk a little bit more about the breast center and the prevention clinic.
So we've reviewed a little bit of this already, so I don't want to belabor it too much just because there's some, exciting things on the horizon. In general, we're happy to see lots of patients. We again have our advanced practitioners really cooking at this point in terms of their ability to do either virtual visits or in-person visits. So anyone under the age of 70, or even if they're over 70, we're happy to discuss their lifetime risk, their breast density, and those with a family history, if they'd like to come in to have assessment to make decisions about whether they should be referred to a genetic counselor, or any prior history of atypical cells. Next slide. But to be honest with you, we're not seeing them. So this is some data that we got from the risk assessment that's performed and all the screening mammography done at Newton-Wellesley. And so this just plotted out those patients. We do about, this was in FY 27,000 screening mammography, or 2019, and about 15% of those patients were over 20%. In our center, we've probably seen about 250, and it's kudos to you. I mean, I think that the PCPs and gynecologists in Newton-Wellesley are fantastic. They take on so much and they do so much. But we do have flexibility and availability if you feel like you'd like us to see them. We also want to make sure that people are clicking on the link that's associated with the mammography. There was a period of time when that document was just scanned into media, and some of the PCPs and gynecologists had no idea that it even existed. And that is a scary scenario because we are collecting this data, and we've got to make sure that we're following through from it because there is legal aspects associated with it. So we're here for you. We're available. Click on the link and feel free to send your patient. We'd never send them away. Next slide. And then in the spirit of, making lemonade, as I keep saying, out of lemons in the era of COVID, Dr. Dang and I and Dr. Commander have talked a lot about potentially changing the way you can refer patients to our center. As I came from Mass General, what I was used to is that the PCP or gynecologist just put the referral in to us, and we took care of pretty much everything. The current process that we inherited at Newton-Wellesley is that really, again, the PCP and gynecologists are doing the heavy lifting. That is, they have a patient with a breast complaint, they need to order breast imaging, and that's always a conundrum. I put many of these orders in myself, and I never know what to click, what needs to be ordered. I get emails and in-basket messages from you guys. And then you guys schedule the imaging. And then if this imaging is negative, perhaps the patients will be seen for an evaluation of a clinical exam. Perhaps they won't. Perhaps you'll feel comfortable with the imaging based on your clinical suspicion. Next slide. What we hope to do is to take some of that burden off of you. And so we would like to transition to really a comprehensive breast care center with comprehensive care. And that is when you have a patient with a breast complaint, we'll ask you to put a referral into the breast center. And from there, we'll take it. So our schedulers work very closely with Dr. Dang's schedulers to figure out, is it a right breast ultrasound if they're over 30 or over 40? Do we need a diagnostic imaging? When was their last? And all those fine details get booked. And then in conjunction to that, we can book a visit with either one of the surgeons at our center or one of our advanced practitioners for evaluation. And I think that's gonna, keep us all safe because as we know, when someone presents with a palpable lesion, really mammogram, ultrasound, and a clinical breast exam is the appropriate pathway. In addition to that, if you have patients with a breast complaint, have had outside imaging at an outside hospital, we put into place a really wonderful outside interpretation process. And so again, you could place the referral in Epic. The nurse navigators in our breast center are fabulous. They will obtain films and pathology reports from the outside hospital, get them uploaded into our imaging, and then allow us to evaluate the patients. We'd love feedback on this. We'd love to make this change. I don't want to do anything that you're not used to, but I do think that this is going to be an exciting opportunity for you and our patients. Next slide. Here is the referral to the breast center. Don't get too hung up, as Dr. Dang and I were trying to sort out, do I click off oncology or surgery or general breast health or high risk? Our administrators and schedulers work very closely together. And so as long as you're picking one of them and then you're picking what the complaint is, we can sort through the appropriate location for the referral. Next slide. And then the last thing that I want to outline is just quickly some of the exciting things that we've transitioned to in our surgery world. For years, we used wires to localize non-palpable breast lesions, and they were tried and true. They did have limitations such that they always had to be placed on the day of the operation. They had limitations in terms of pain, and they had limitations in terms of potential for dislodgement. And so about 3 years ago, we have moved to a wireless system. And so this represents a tag, which is actually a radio frequency emitter that allows us not to have to use these wires. And so the tags are placed in the same mechanism that the wires were placed. However, they can be placed days before the operation. And so the tags can be placed 30 days before the operation up to the day of the operation. And by placing these tags beforehand, selfishly, it improves the efficiencies in the operating room, because that means I could do the operation at 7:30 in the morning and not wait for the radiologist to have to do their part of the procedure. But it's also more comfortable for the patient. As you can imagine, for an operation, you come in with nothing to eat after midnight, and to have a wire placed and be under compression on that day, it's a challenge. And so having these tags placed prior, we wrote a study, one of the fellows and I, which compared 356 wires to 147 tag localization procedures. It was safe. There was no different in operation time or specimen time or rates of re-excision, but it did have an increased satisfaction with patients and the operating room efficiencies. Next slide. And in addition to that, we're able to tag lymph nodes in the axilla. So increasingly, we are doing operations such that we're avoiding axillary lymph node dissections. We're giving patients chemotherapy to reduce node-positive disease and therefore be able to spare the patient an axillary node dissection and the risks associated with it, such as lymphedema. We therefore can place this tag in the lymph node that used to have cancer in it, and then on the day of the operation, be able to excise that lymph node, have it tested via frozen section, and if the chemotherapy has essentially created a complete pathologic response, we can spare them those axillary node dissections. So this is a study that another one of my fellows published just recently. By using these tags, we spared a huge percentage of patients axillary node dissections, and we only were able to move to this technology by getting away from the wires. And the last slide. And so the last paper that we actually just got published was a COVID paper. It was a paper in which I had created a new algorithm for discharging patients who've had a mastectomy with reconstruction on the same day. And it was a project that I began in December and worked through over January and February. But when things hit and patients were not allowed to have family members in the hospital and not allowed to and be in COVID hospitals, it took off. And so we published 15 patients we treated during the month of March, and this was across both our campuses, where patients would receive really good preoperative medication. They would get their scripts ordered preoperatively. They would have to watch a video about their drains. We performed paravertebral blocks, which the anesthesiologists in Newton-Wellesley have been doing routinely. We made sure to give them antiemetics, and then set up a visiting nurse to come to their house on the day after the operation. So super exciting. This got accepted. It's been kind of a template for other surgeons around the country, and we've now discharged up to 65 patients since that time. So we've made a lot of progress despite operations during that month of March. Thank you. That's all I have.
Thanks very much, you guys. I just wanted, there's a couple of questions in the chat box, just throw right by the last 2 minutes. Dr. Norwitz is thanking you for an excellent summary and wants to know if you can comment on which patients should be referred for further genetic testing. Is this a decision your team would help with, or the PCP? And then I'm going to ask another question and then stop talking, which is, there's a second question, which is, any way for the breast center to directly order biopsies or diagnostic 6-month diagnostic mammo when they recommend it to save a call to the PCP? We end up having to put those orders in, as you guys know. You're on mute. I don't know who's going to answer, but make sure you unmute yourself.
So yes, we can take care of the genetic testing. I think we have a wonderful collaboration with the genetics group. We've really, during COVID, gone to a lot of utilization of at-home testing and virtual visits. I do think that the queue for just routine genetic testing is quite long, and allowing us to see the patients beforehand to really, figure out who really needs it might help the process. You can refer in either way, whatever's easier for you. There is a chance if we see them first, you might get in sooner. It shouldn't be that way, but it may happen that way.
What about the process of ordering the test itself?
Are you talking about the second question?
Yeah.
So breast biopsies, I can take that one. Breast biopsies are, the ordering, it has to be co-signed, but we basically schedule and, schedule the biopsies, and then we put in the order and we just send it to our providers for co-signing, and almost all our patients are directly scheduled by breast imaging before they leave our department. In COVID, we've had some processes with checkout where we cannot schedule it, but we call the patients within the same day and schedule the procedure for them. So it should just be a co-sign for biopsies. For 6-month follow-up at this point, because of COVID, we cannot have checkout appointments, but in the future, I think our goal is to be able to schedule those as well, which can save PCPs, and all they need to do is co-sign that.
You want to handle the next one, Priya?
Sure. So gadolinium is a question we often encounter, and of course it's a long discussion, but there are some data on gadolinium deposition in the brain. But if you break it up, gadolinium agents, what I tell my patients are there are two types. There are macrocyclic and linear agents, and there are some agents that have been shown to deposit in the brain, and we don't use those agents. Most of the studies are on linear agents, but we use macrocyclic agents. But yes, there is some degree of deposition, and nobody knows what the clinical implications of that are. So there aren't enough data as to what the clinical implications are, but the agents we use have not really shown to deposit in the brain. And that we're aware of these, we're mindful of these downsides. So, studies are going and research is happening as to what can we do in the future for, performing high-risk screening MRs without the administration of contrast, but we're not quite there yet.
Okay, and there's another question about when we should stop routine mammograms in the average risk patient.
This is a talk in itself. It's a controversial topic and different guidelines for different patients, but how I tell my patients, which the American College of Radiology says as well, is there is one size doesn't all. So you really have to see, the comorbidities or what is, the life expectancy of a patient, whether it's 5 years versus 10 years. And that makes a difference. There could be a very healthy 74-year-old who wants to get mammograms and should get mammograms, versus if someone is really frail and will not undergo any, management options after we do a mammogram, then there is no point getting a mammogram in that patient. If they cannot even undergo a biopsy, then it's not worth it. So I don't think according to the American College of Radiology, don't recommend a date to stop, but it's more dependent on the patient and if they can undergo the further, tests needed as well as treatment if a breast cancer is detected in them.
And the one thing that I would implore is, I do teach the medical residents who rotate through my clinic, if you're stopping, just at least ask the patient if they have a lump or a bump. Certainly in encountering, someone who may have Alzheimer's or limited memory, and they present with a 2-centimeter or 3-centimeter cancer because no one's thought to do a breast exam. It's helpful because it really makes a big difference in terms of the surgical procedure. I can easily excise something that's 1 or 2 centimeters, you start getting to larger, and then we have to do general anesthesia and a whole bunch of stuff.
Terrific. Well, thank you guys so much. I think our PCBs are going to love that new flow of just referring straight to the breast center. So I really hope people will take advantage of that. I appreciate everyone who logged on this Thursday. We'll see you next Thursday for a discussion about melanoma. I did put the CME code up before, so if there's any problems, you guys can all email me. Have a great Thursday and a nice weekend. Thank you all.
Thank you.